Okay. Hello again, everybody. Thanks for joining. This is the second part to the Critical Care Hot Topics series. So the first session, if you were able to join last month, was about shock, sort of undifferentiated shock in the most general sense possible. Figured I would break it up into two different presentations. So this month we're going to talk about all the different types and subtypes of shock. The most common ones that you might see. This is probably going to be a review for a lot of you, but if it isn't, I guess that's why we're here. And then I did put in a couple of case studies or examples of different patients. They're pretty like basic examples, if you will, with like minimal detail, but I think it sort of gets to the point. So if there is some questions, which I'll give everybody like a minute if you wanted to try and type in an answer. Still trying to get used to all this technology, but I'll just give everybody the answer. No one's getting quizzed today, so yeah, it's gonna, like I said, we're gonna differentiate between the different types of shock. Talk about the different nursing interventions, medical interventions for each type of shock, and then look at a few case studies, like I said. So just as a review, the different types of shock sort of all speak to this like general idea of a shock state, which is, in the most general sense, a mismatch between cellular demand and supply of oxygen. So, which results in an acute, widespread process of impaired tissue perfusion, which results in hemodynamic alterations. And depending on the type of shock, which we're going to talk about in a second, you're going to have different hemodynamic consequences. So, the four main groups of shock, or the types of shock, are there. So hypovolemic, cardiogenic, distributive, and obstructive shock. And within those groups, particularly distributive shock, you have two main types. So you have septic shock, or sorry, three main types: septic shock, neurogenic shock, and anaphylactic shock. Obstructive shock, there's a few different causes of obstructive types of shock. Cardiac tamponade, tension pneumothorax, pulmonary embolisms would be good examples. In hypovolemia, probably a second most common type of shock. Anything that results in intravascular fluid or volume loss, so hemorrhage, dehydration, things like that. And definitely the most common type of shock, which we'll talk about in a minute, is septic shock. It's a subtype of the distributive type. So yeah, we'll just kind of jump right into it. So hypovolemic shock results from an actual or relative loss in circulating blood volume. So a good example would be a hemorrhage. Relative fluid volume loss as a result of a burn, poor fluid intake, dramatic shifts in intravascular, intracellular or extracellular fluid volume as well. GI losses, excessive diuresis, anything like that, anything that's going to increase volume loss. And there's a little bit of a sort of a continuum here. This is a classification in children. It loosely applies to adults as well. There's different classes, class 1 to 4. So if you look at the severity of shock, often it's referencing these classes. And it's all in relation to the percentage of intravascular fluid volume loss. And as you progress through the different classes there, from 0 to 15% blood volume loss to over 40, you start getting a progressively increasing severity of shock symptoms. So from tachycardia, normal tension, to slightly decreased blood pressure, significantly decreased blood pressure with profound tachycardia as your heart tries to compensate, And as the fluid volume, circulating fluid volume becomes much lower, your pulse pressure starts narrowing. The difference between the systolic and your diastolic pressure. So that's sort of characteristic of hypovolemic shock. And then you're going to hear this a lot, but in the end or the final class of shock or hypovolemic shock, you sort of progress to this MODS state, multi-organ dysfunction syndrome, which is very severe and often life-threatening. You have elevated LFTs, basically evidence of every major organ system is impaired, DIC, cerebral hypoperfusion. So how do we treat it? I mean, we detect, hopefully we catch this early. As somebody is compensating, especially in children, they can compensate for a long time until they take a dramatic turn. But in the case of adults, like there's a typical progression through these classes where the early stages can, like class 1 to 2, depending on the cause, even something like an infection or dehydration can be sort of protracted over a couple of days. So identifying that there is symptoms of dehydration / intravascular fluid loss, so we control whatever's causing that. If it's bleeding, obviously stopping the bleed. That's easier said than done when we have a GI hemorrhage, so it's internal. But IV access, often multiple IV sites is the best strategy there, especially on presentation to emerge, and then rapid administration of IV fluids and blood products. Using vasopressors as an adjunct to increase our circulating blood pressure in our MAP. Targets generally 60 to 65. I'm going to use that loosely. I think every sort of care area and physician group has a different initial target. We talk about sepsis. The Canadian Critical Care Association recommends targeting 65, but again, I'm going to use that guideline as a general rule. So cardiogenic shock, think anything that can cause a failure or decreased function of the heart's ability to pump, which in return decreases cardiac output, so stroke volume and or affecting your heart rate. So really anything that's going to increase or decrease cardiac output or affect any one side of that cardiac output formula, which is stroke volume times heart rate. So this chart sort of shows the different causes. You have the different cardiogenic causes: MI, severe right ventricular infarction, myocardial infarction that's severe enough to really any area of the myocardium. Advanced septic shock, anaphylactic shock isn't really on here, but that also results in coronary artery constriction and therefore decrease in cardiac output. There's mechanical causes: ruptured valves, prolapsed valves, ruptured myocardial walls or septums. And then you have your arrhythmias, so your VT, atrial arrhythmias, and your bradyarrhythmias. So those are all sort of encapsulated under this cardiogenic shock umbrella. Generally, sorry about that. I'm in the hospital, so just getting an emergency. So yeah, generally, when sort of recognized early, especially in the arrhythmia side of things, if you can intervene either immediately or very early, mortality significantly improves. But this mortality rate associated with cardiogenic shock is generally higher than the other types of shock, 50 to 75%, especially the more severe causes. But yeah, these are the general signs and symptoms of cardiogenic shock. So it obviously depends on the cause and the severity of the shock. You're gonna either have bradycardia or tachycardia, whatever's causing that cardiogenic shock in the first place, but or you can have dysrhythmias as a result of the pump failure or causing the pump failure. But the key is you can have hypotension associated with this. So it's dramatic, it's an acute drop in blood pressure. Unlike hypovolemic shock, there isn't this progression of things. It's just sudden, severe hypotension, often life-threatening. Pulmonary edema, if things are sort of prolonged a little bit, in the case of a prime example, there would be an MI that's causing pump failure, particularly left ventricular failure, altered level of consciousness, multi-organ dysfunction syndrome, same thing, the other types of shock as well. And the treatment is, again, exclusively targeting the cause. So if we have a suspected or an actual MI occurring, PCI fibrinolysis, depending on your hospital site and access to a primary PCI site, CABG, if our patients have like known coronary artery disease or multiple blockages that are identified on an angiogram, that PCI would often be like a bridge to more definitive treatment, supporting the patient through that shock state with inotropes, vasopressors, and treating arrhythmia as they sort of occur. The only caveat there is the only thing that's different that we didn't really talk about is avoiding beta blockers and calcium channel blockers, which is sort of a mainstay of treatment or management post MI. If you've ever had somebody immediately post PCI or angiogram, we like to give things often in Emerge, actually, IV metoprolol, anything to sort of improve that oxygen supply and demand sort of calculation. Somebody has tachycardia or myocardium is needing more oxygen, and our coronary arteries fill during diastole. So it's often a strategy to improve the hemodynamic picture of somebody presenting with a STEMI, for example. But it can often lead to a worsened shock state in cardiogenic shock. So, there's often this moment where our patients are initially stable, and then they may deteriorate after a large infarct. And then we have to sort of roll back some of those initial treatments and hold beta blockers, calcium channel blockers, things like that. Another good thing to mention for those of you in the Emerge sort of crowd, cardiogenic shock in the context of an overdose of calcium channel blockers, beta blockers, there may be very specific treatments that are identified by poison control, like high dose insulin, dextrose, glucagon administration, things like that, to sort of augment the bradycardia and hypotensive effects of those beta blockers or calcium channel blockers. So that would sort of like be wrapped up in the same type of shock, I would think. So this large category of distributive shock is by far the most common type of shock. It includes septic shock, anaphylaxis, and neurogenic shock. So in the most general sense, these types of shock are causing a widespread global vasodilation that causes a relative drop in intravascular fluid volume, just because your blood vessels are getting much larger. And it also increases vascular permeability globally, so throughout the body, which causes a lot of neurological, pulmonary, GI symptoms in the case of anaphylaxis. So there's relative and then actual of intravascular fluid loss in the case of sepsis. So yeah, that's the sort of general mechanism. But in the case of anaphylaxis, all of those systemic vascular dilation is occurring, but you also have constriction of the upper airways occurring, so which is often the initial and the most dramatic sign of anaphylaxis. So for those of you that have seen it, or patients sort of know when they are having an anaphylactic reaction as a result of exposure to an immunologic or non-immunologic cause. So this chart sort of identifies what cells are mediating this this hypersensitivity reaction. Regardless, the same sort of things are happening systemically. And the key treatment with any anaphylactic reaction is early epinephrine. It's going to do a couple of things. It's going to actually reverse the global vasodilation effect. So increasing blood pressure, improving that vascular permeability, so like preventing any additional fluid loss, and then also reversing any laryngospasm and airway emergency. So, I mean, any anaphylaxis that progresses to the shock state, you're going to get all of these symptoms, hives, all the respiratory symptoms that are typical with anaphylaxis, cardiovascular symptoms, reflex tachycardia, hypotension, chest pain causes, instead of arterial dilation, systemically it's going to cause coronary vasoconstriction, nausea, vomiting, diarrhea, all these other fun things. But the initial dose of epinephrine IM is 0.5 milligrams. You can give that up to 3 times, generally speaking. There's been cases where sometimes you get to the first, second dose. Sometimes we just abandon that and start an epinephrine infusion. As you see, you get lower down in that treatment protocol. You can often make those decisions, or physicians make those decisions with us. Some other adjunct medications, you've probably given Benadryl, ranitidine, in your steroids. But if you haven't ever had experience with anaphylaxis, you're often like given all of these things at once as a part of like either an anaphylaxis medical directive on presentation to emerge, or maybe even a care area in your hospital PACU. It's another common one. Patients come in for surgical procedures. We don't necessarily know if they're going to be allergic to a medication that we give them. And so you have all of these things available to you. But like I mentioned, the most important intervention with any anaphylaxis reaction is the early administration of epinephrine. It'll actually reverse all of those physiological causes of this shock state. Another subtype of the distributive shock is a neurogenic shock. And this is a result of loss of or suppression of that sympathetic tone from the spinal cord. Common in spinal cord injuries. And it results because we're losing or severely diminishing that sympathetic tone. It's going to result in massive vasodilation, impaired thermoregulation, and inhibition of the baroreceptor response. So it should be respiratory symptoms as well. So, you know, every physiological process that that your spinal cord is responsible for is going to be affected if you're losing that sympathetic tone. Bradycardia, hypotension, and I'm not even going to attempt to say that word, but impaired thermoregulation, warm and dry skin because of vasodilation, and increased respiratory rate. So all of these interventions that we've sort of been talking about, vasopressors, inotropes, pacing, even with atropine chemically, or transcutaneous pacing, and environmental temperature regulation or management, either by way of a cooling machine or a warming machine or blankets. So our patients can't do that themselves. So they need a lot of support. There is often a confusion between spinal shock and neurogenic shock. Often the terms are used interchangeably. But think of spinal shock in exclusively the like epidural or spinal context. If the patient's getting a spinal block or an epidural placed, they can have an acute like injury or like an insult to that area of the spinal cord, and they can lose all voluntary and reflex activity below that level. It's transient, so it can last hours, days. So that's a key diagnostic characteristic, and it does not cause any hemodynamic shock symptoms or signs, as opposed to neurogenic shock that is a complete or relative loss of that sympathetic response. So just sort of make that distinction. There is, I mean, depending on the severity of spinal shock, you may also have some associated bradycardia or vasodilation, but you don't have all of the neurogenic shock symptoms that you would have with a huge injury or of the spine, particularly in a trauma patient. So You may have some patients requiring vasopressors like phenylephrine that exclusively act on those alpha receptors. Also a good drug of choice for neurogenic shock patients who may not need any medication to increase their heart rate, but they have severe hypotension because of that vasodilation. That phenylephrine exclusively acting on those alpha receptors is just going to cause constriction of the arteries. And here's the big one, septic shock. Definitely the most common type of distributive shock. It sort of occurs on a continuum between sepsis, SIRS, and septic shock, or SIRS, sepsis, and septic shock. SIRS, or systemic inflammatory response syndrome, can be caused most commonly by bacterial infection, but can be caused by a whole host of other things: myocardial infarction, trauma. Really, any reason our patients may be admitted to ICU. Something like 75% of patients that get admitted to intensive care units have SIRS by definition, but only 10% of those patients have septic shock. So the septic shock end of the continuum is severe hypotension with the presence of SIRS and sepsis. And then what does SIRS mean? You're impaired either a high temperature, over 38 degrees, or under 36, so hypotension or hypothermia, sorry. Tachycardia, your respiratory rate is over 20, or your PaCO2 is less than 32, so you're tachypnic, and you either have high or low white blood cells. So you have to have 2 or more of those things, and you sort of meet the diagnostic criteria of SIRS. So once you reach that septic shock end of the continuum, a few things are happening. Our patients have sort of entered a state where they have a pretty severe infection with a dysregulation, that physiological response, either because of toxins that are being released by a particular bacteria, virus that is circulating, or just an impaired response because of immunosuppression that was pre-existing or otherwise. So the same physiological mechanism that's occurring in both anaphylaxis and neurogenic once you reach this shock state. So like profound vasodilation and increased vascular permeability that results in peripheral tissue ischemia. DIC is another characteristic of septic shock, mediated by some of these endothelial responses. You see this on this chart here. And then further immunosuppression. And then MODS. But like I said, the symptoms and signs of septic shock, neurogenic shock, and anaphylaxis once we reach this the end shock state is quite similar. Tachycardia, hypotension, requiring vasopressors, a significant fluid resuscitation requirement, because you have this relative loss of circulating blood volume with this vasodilation occurring. Obviously, before we start vasopressors to reverse that, but an actual fluid volume loss because of the increase in vascular permeability. So patients often require liters of fluid resuscitation. And as a result, decreased urine output, increasing lactate. This is a diagnostic sort of stratification score. qSOFA is another is the name for it. It may take different forms depending on the charting system we use. Sometimes it's incorporated into like EMR systems, or physicians may just do this on their own with UpToDate or things like that. It sort of gives us a quick reference to sort of establish how severe someone's shock state is, septic shock state is, by incorporating those 3 indicators there: tachypnea, or respiratory rate over 22. Are they hypotensive, and do they have a altered mental status? So he says there, anything greater than or equal to 2 is associated with significant increase in hospital mortality. So yeah, again, just like some of the other sign or types of shock, the key is to recognize this early. But this is from the Surviving Sepsis campaign, the 1 hour bundle. There's 1 in 3 and 6 hour bundles, sort of what we should be doing initially, and then at 3 and 6 hour mark. So that these have been shown to significantly improve in hospital mortality rates with septic patients. But things like obtaining lactate in blood cultures immediately, and early administration of antibiotics within 1 hour of identification. Obviously, because we've just obtained those blood cultures, they would be broad spectrum antibiotics, and then we would tailor our therapy accordingly. But fluid resuscitation, like I mentioned, is very important, especially for our patients who are already in a profound hypotensive shock state when they either present to us or we find them on an inpatient unit if you have a critical care response team or you're called to help. Vasopressors and all the other supportive care measurements if they have respiratory compromise, supporting them to breathe as well. So yeah, that's septic shock. The final, I believe this is the final general type of shock is obstructive shock. So it's anything that's going to cause the impedance of blood flow to or through the heart, either the right or the left ventricle. So any obstruction within the circulatory system, for example, any thrombus, pulmonary embolisms, myxomas, or emboli of any kind, and or obstructions outside. So tension pneumothorax, cardiac tamponade, so the fluid or air accumulation around the heart. It's going to impede its ability to actually fill and eject blood from it. Abdominal compartment syndrome is a relatively rare but interesting example. You think of patients of severe ascites. Another interesting example would be cavocompression. This is exclusively seen in pregnant patients. That's why we don't lay them supine, because it can actually impede this inferior vena cava's ability to return blood back to the heart. Sort of propping them on their side to allow proper blood flow back. This is an example of obstructive shock that you can sort of intervene and prevent. But this type of shock often has a very dramatic and acute presentation caused by that results in tachycardia, hypotension, tachypnea, shortness of breath, increased JVP, as blood is blacking up in the venous system, and then inevitably altered level of consciousness. We may or may not get to a point where you have evidence of oleuria, because it is such a dramatic cause, especially in the event of cardiac tamponade. Depending on the cause, I mean, I think your frame of reference matters. If you're coming from the emergency department, you're seeing a lot of patients as a result of trauma. In a normal adult patient, for example, even something as small as 1 to 200 mils of fluid in that pericardial space can be enough to cause hemodynamic response. But in patients who present to like a cardiac care unit because of a large or even a moderate, it's my favorite, moderate sized pericardial effusions, usually very large, that they see on an x-ray or something like that. The most common cause for large fluid accumulations is cancer. So that occurs over more gradual period of time, and you can have really dramatic fluid volumes, even as high as 2 liters of fluid coming out of someone's pericardial sac there. Yeah, these spontaneous or traumatic tension pneumothorax, tension hydrothorax would be another example. It's not really commonly mentioned, but pleural effusion can cause the same, sort of as if there's a hemorrhagic source, or I like to use this strange example that was occurring for a short period of time, where we had patients treated for pleural effusions on inpatient units, and and our physicians would ask us to clamp the chest tubes so as to minimize any drainage from the pleural space that was over 2 liters. These patients were having 2.5 liters drained within 4 hours on an inpatient unit, and that was causing, because of lack of communication between physician groups, and then the nursing staff didn't know when the previous physician had ordered it to be clamped. The patient then sort of deteriorated and became hemodynamically compromised. They're hypotensive tachycardic because the fluid was just continuing to accumulate the same way pneumothorax would. So tension hydrothorax would be the example there. And then, reversing the cause. If it's air, if it's a tension pneumo, because of a trauma, a stat like needle decompression, it could be as simple as literally sticking a needle into the patient's through their ribs. This is obviously something a physician is going to be doing. Chest tube insertion, TNK in the case of a pulmonary embolism, or embolization in a interventional radiology suite, depending on the patient's ability to actually get there. But pericardiocentesis in the case of tamponade. I did want to mention supportive care is sort of mentioned there because it's mentioned in generally every management of every type of shock. This, if you've ever seen a patient with an obstructive type tension pneumothorax or with a accumulation around the heart there, tamponade, the effect is dramatic, and they don't make it to the point that we actually need to provide them with supportive care. So it's either they dramatically improve because of our interventions, or they will deteriorate to the point where they unfortunately succumb to the effects of the shock. So yeah, quite dramatic. So there's 4 general case studies here. I'm just going to sort of talk them over. If you wanted to type in some answers to these questions, go ahead. I'm going to tell you the answers anyways, but so with this case, your patient presents to the ER with 5-day history of melena stool and having had a large melena stool this morning. So they're pale, they have cool extremities and delayed cap refill. Their initial vitals are 36.4 is their temp, heart rate is 125, their BP is 95/67, their respiratory rate is 26, and their SATs are 94% of room air. So what type of shock do you think this may be? And you may be looking at that blood pressure going, that's not really that bad, but the heart rate's kind of telling there. And their presentation, they have a history of melena stools over the last 5 days, having had a large bowel movement this morning before coming into us. It's a classic example of hypovolemic shock. Thank you. They're compensating at this point in this case. So, but they do need some help. We'll get to the point there where, depending on the level of actual circulating blood volume is lost, that their blood pressure will be affected in a much more dramatic way as more and more fluid volume decreases without replacement. That pulse pressure will become more and more narrowed. The difference between the systolic and diastolic number will become less and less. And then what are some of the actions? How do we know that some of our interventions are successful in this patient? Sort of a trick question. Yeah, the answer is E. All of those things, right? Normalizing blood pressure, our skin color and temp improves, heart rate normalizes. That's often the first effect. It's quite dramatic. Even with just fluid resuscitation, crystalline fluid, our heart rates should start to see that come down. Second example here. You're caring for a patient with a new spinal cord injury. They become bradycardic, hypotensive, and lose all neurological activity below that level of injury. So what type of shock do we suspect? It is neurogenic shock, sort of a trick question. Often that spinal shock terminology being used in conjunction with or in exchange of the neurogenic, but just remembering that hypotensive state doesn't really occur with spinal shock. It's usually exclusive to the motor function of the spinal cord, and it's transient. So yeah, and then what's not one of our priorities in the situation? Yes, obtaining blood cultures is, I mean, unless we're also suspecting an infection, it's not generally going to be one of the priorities. And yes, I could see rationalizing calling for help is not a priority, depending on your area. If the patients are coming into the emergency department following a new spinal cord injury and we get advanced notice, often everyone who's going to need to be there is already there anyways. So you're in CT with your patient, they develop hives, become tachypnic, restless, and stridorous after injection of the contrast dye. When you check their vitals, their temperature is 37.1, heart rate's 140, blood pressure is 100 over 55, respiratory rate's 35, and they're satting 90% or room air. What type of shock do you suspect this is? Anaphylaxis is the right answer. And what's not one of our priorities? Exactly. So you'd probably want to do all those things, especially if you're by yourself with your patient CT. If that's ever happened to you, it's really fun, sarcastically. But this is, again, one of those cases where, like, the earlier you can get epinephrine and get it into the patient's arm, the better they're going to be. Because as you can see there, we're not really having a tremendous hemodynamic response. It's generally an airway emergency that's going to be reversed by the epinephrine anyways, and then you're going to prevent all those hemodynamic effects of anaphylaxis by either that one and only dose of epinephrine, or perhaps if they need an additional dose depending on their ongoing symptoms. So this is the last one. So you're taking care of a trauma patient. They sustain blunt trauma to the chest and suddenly become more tachycardic, tachypnic, and develop hypotension. When you do a focused assessment, you notice their neck veins are bulging and their heart sounds are muffled, difficult to hear. What type of shock do you suspect? It's obstructive, yeah. And then the mechanism that's causing that obstructive shock for this patient is could be tension pneumothorax. Absolutely. I mean, I think the key for this scenario was the blunt trauma to the chest. Most likely would be cardiac tamponade. I think we would need a chest X-ray to sort of rule out tension pneumo or cardiac tamponade. Or B, yeah. And then in that case, if it was a tension pneumothorax, their primary intervention would be a chest tube insertion or needle decompression. And if it was cardiac tamponade, pericardiocentesis would be the primary intervention, which is essentially a needle decompression of the pericardial space there. So that's it. If anyone has any questions for me. Thank you. I'm just gonna stop the recording here. I could stay on for a couple minutes.